right, so now pretty much everything I'm about to go over is absolutely on the Online Resource Center. Okay, so if you check on the chat down below, you can type me a question. Pretty much everybody is ready to go. Okay, if you have a question, please chat it. That'd be great. If we have too many people with an open mic, it could get a little bit crazy. So check in with everybody. If everybody give me a hi on chat, that'd be fantastic. So I know everybody can hear me and we're good to go. Okay, so commonly asked questions on the Neon Trac. Probably the biggest question I get is, how do I get more training? And the simple question, the answer to that question is the Online Resource Center. Ergo-Flex Technologies, you'll see the online resource on the top. In there, there are multiple videos. There are videos on troubleshooting, actually some assembly, disassembly. If JT needs to get on the phone with you and make sure that it's working properly, he can do that. There's proper patient setup videos. This is critical, 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 critical. Okay, you have to be skin on skin. Okay, if you do not have the magical traction grip strip, then just let us know, because it's real simple to make. You just get some drawer liner material, cut a 4 by 12-inch strip, and then you actually put that around the knee, excuse me, under the knee, around all the way, and then actually put your strap on. That makes a huge difference on how it works. So, why am I not pin video? There we go. So on that, how that actually works. I'm all over the place. So if you've got a patient that has a very slender calf, it basically has no meat, you need to make sure that you're getting a really good entrapment right there at the tibial plateau. The top of the pouch that actually holds the bladder should actually go right beneath the inferior pole of the patella. Trap the entire patellar ligament and trap that. When you set it up that way, it is basically entrapping all the insertion points for the 6 muscles in front of the knee and 6 muscles behind the knee. When you do that, you get a very good entrapment of the tibia and tibia plateau. You also create a neuromuscular event that retrains the body's neurological pathway on how to reset and relax. So that's a very, very important mechanism. You are not only stimulating muscle spindle, but you're also stimulating the Golgi tendon, mainly muscle spindle with the Neon Trac, because it is simply axial. So proper patient setup is critical, skin on skin. If you don't, if you got a patient that comes in pants or someone, then you go down to the local, go to Academy and pick up a bunch of basketball shorts that are really, really, really big. That's what I used to do. Put them in that so that you get skin on skin. It is critical, especially for somebody that does not have just a lot of meat in their gastric or soleus. The next one is proper bladder deflating. So we get this all the time. I mean, it's not all the time, I shouldn't say that. About once every 2 weeks, we had a doctor that calls in and said, hey, my bladder's not working anymore. This is a very simple thing to fix, okay? We can ship you another bladder, okay? As it stands, they're not technically covered in your warranties, but we typically will take that into account, ship you one, and then after that, you're going to be paying for the rest of them. The reasons why they typically fail is not because of the material that they're made of, but because they don't get deflated properly. That bulb is a blood pressure cuff bulb. It is a metered exhaust. So when you're taking blood pressure, it doesn't just dump all the air out. So the first thing that you should do, or you could possibly, I trained my patients to do this, is to reach down and counterclockwise the bulb knob. When you do that, that lets all the air out. I simply have them squeeze it a little bit, deflate it, and make sure that all the air is evacuated from that bladder. Because you only need 6 to 8 pumps. 1, 2, 3, 4, 5, 6, 7, 8, maybe a little bit more for somebody who's really, really thin. and that's it. But if you don't evacuate all that air in that bladder, the next time you're now starting off at 8 pumps, and now you got to go to like 22 pumps, all right? So that's how that bladder gets overinflated. That's how it actually begins to fail. We are working on some other ideas on how to change that, but for now, it's almost always a simple training error. Just make sure that the air gets completely evacuated out of the bladder, each and every patient, and you'll actually get better traction because of it, because it's designed to actually start off with a snug fit, and then the bladder is actually what entraps tissue. Then how to actually remove the patient. That goes back to that step I just talked about. Even has a short video on contraindications for the knee, how to protect the electronics, because occasionally like an electrical storm will knock it out. Then talk about skin on skin and bladder replacement, because we do get that some often. There is a kill switch video on there. We quit sending kill switch because they basically, patients would actually hit them and they weren't plugged in all the way. We just took that, we're going to take that video out. If you don't get a kill switch, it's okay. You have the quickest kill switch ever. You just unstrap the knee. Just take that tibial plateau strap and undo it. So anybody have any questions? Dr. Talley, yep, I know you don't have one. We didn't send you one. We're not sending them out anymore. Or are you talking about, you might be talking about the drawer liner or the shelf liner strap? Pretty easy. Okay, so I answered, how do I get more training on the Trac? How many protocols and which is the most popular? So there's 5 specific protocols. The first one is static. So let's say you set it at 15 pounds. It's going to go out and hold it at 15 pounds, okay, for 360 seconds or 6 minutes or 5 minutes or 10 minutes, whatever you recommend. Now, I recommend a 6-minute protocol when we're doing intermittent traction, and that's protocols 2 and 3. 3 is the one I use the most often. Protocol 3 is the one that I pretty much used across the board. That is, it basically, let's say you have a 175-pound patient that is not a high-impact athlete. I'm going to start them off at 15 pounds, protocol 3 for 6 minutes. And it will move it all the way out to 15 pounds, hold that for 30 seconds, and then back off 25%. Excuse me, hold it for 60 seconds, back off about 25% of the poundage, and hold it for 30. So 60 seconds hold, off 30, 60, off 30. Protocol 2 is a 1-to-1. It holds 60, releases 25% for 60. That's the only difference between those 2 protocols. I personally like protocol 3 better. There's a neurological mechanism in there that you basically only need to hold it for about 10 seconds to get the Golgi tendons activated. That's one of the main reasons why. Oh, didn't understand it was a drawer liner. I got you. Okay. We can send you one, but a drawer liner. Yeah, that drawer liner material, it's great. Here's the side effect of using the drawer liner. If you're not setting them up, you got a staff member setting them up, and you see them walking in for their adjustment, and you see all the little crinkle marks on their knee, you know exactly if it's being placed correctly or not. If it's being placed 3 inches down into the calf, the big meaty part of the calf, you'll see that. That's not where you're supposed to, you shouldn't entrap there, okay? All right, so protocols 4 and 5. Gradient traction is 4 and gradual traction is protocol 5. Either one of these work really, really well. One works on a percentage basis. The other one works on like a 2-pound increment basis. This is the one I use mainly for post-surgical knees or acute knees or a total knee replacement. Total knee replacements do fantastic on the knee on Trac. I'll get into that a little bit more. There's an entire market that has been completely untapped. You talk about somebody that, number 1, doesn't want to have a second knee replacement, but number 2 has had bad results because of the first one. The main reason why is because the ligaments that started to fold because they had the joint space loss of the knee that led to the knee replacement. When the medial and collateral ligaments fold over, there's nothing they do in that surgery to actually unfold those ligaments, all right? The best thing they can do is get the leg length as close as possible. Well, if they get a leg length the same length as the good knee leg, guess what? Those ligaments are going to be at full tilt stretch. And if we're not doing anything to unfold those ligaments, which the knee Trac does, they hurt and they get stuck. They get stuck in flexion. They get stuck in full extension because there's nothing that's really being done in post-physical therapy, especially if they don't go to a CPM, a continuous passive motion, immediately afterwards, which most people are not very compliant. Surgeons aren't really all that excited about them anymore, except for the fact that the data is tremendous on them. And typically is nothing in there that actually helps unfold that ligament. And if they do, it's really, really painful, and you get a really painful patient. They don't comply very well. So knee replacements do fantastic on the knee Trac. It is an amazing, amazing event. Okay. So I like protocol 4 and/or 5. I typically use 4. It's just easier to go from 3 to 4 on the dot. That was just the way I did it. All right. How many protocols are most popular? So what poundage should I use? I rarely used anything over 20 pounds. Okay, that was typically my limit, unless somebody was in the 350 plus class range. And then even then, I typically would back them down in poundage. They just tend to do better with less poundage. But you just had some of those people that had a lot of scar tissue needed the extra poundage. So if you got somebody that is 175 pounds or less, and they are not a high impact athlete, start them off at 12 pounds. Okay, start them off at 12 pounds and then begin increasing every 4 visits at a pound. Now, if you want to change their protocol, you can. So let's say you want to start them off in protocol 1, start them in static, and then you move them to protocol 3, to intermittent, or you want to move them to protocol 4 and then 3. That's all great stuff. I typically went straight to 3 if I started them off at static. Static was more of I used it most recently on a very acute quad tear and meniscal injury along with an MCL tear. And the patient did fantastic. So I started him off in static because basically on acute injuries, you're trying to kind of control the swelling event. All right, so you want to unload the joint from a static standpoint initially. That actually opens up, decongests, and then we start getting better movement that way. It gives them pain relief as well. And then I want to move them into an intermittent as quickly as I can. Those are acute cases. We'll talk a little bit more about that. Guys, if you have any questions, please put them in the comments or in the chat section. I'm happy to answer them. So, like I said, protocol 3 is one I use the most often. So when I used in pretty much everybody, it's just the easiest one to use. Poundage wise, so less than 175 pounds, I started them off at 12 pounds, added a pound every 4 visits. If they're 100, let's say they're 120 pounds, but they're a tennis player, or they bang out 5 to 10 miles every other day running, I'm going to start them off at 15 pounds because they're more of a high impact athlete. Same thing goes for, CrossFitters or somebody who's knocking out 200 miles on a bike every other day. Those are more high impact athletes. They need more mechanical input. Now, if they're 175 pounds or more and they're not a high impact athlete, then I'm going to start them off at, 15 pounds. So Dr. Morgan just got on the who is the untapped market. Knee replacement people, yeah. So the total knee replacement market is pretty much untapped. We'll come back to that in a bit. So again, under 175 pounds, start them off at 12, add a pound every 4 visits. 175 pounds or more, 15 pounds, and then add a pound every 4 visits. And I typically stopped at 20 pounds as the ceiling. So now, what protocols are used for what conditions? There is a very specific knee condition, condition-specific knee protocol, and that's where I go into more about what it is. Like just basically what I just said, acute ligament injuries that are grade 1, is typically you want to stay in the protocol 1, and then you move them into intermittent. Your 5+ year osteoarthritis, medial compartment loss, those, they're pretty much all going to start in protocol 3. Total knee replacements, protocol 4 or 5. But you're going to use your clinical judgment. And if you have questions, please ask. Okay, Dr. Talley can tell you I've asked he's answered a bunch of questions, asked me a bunch of questions, which I'm happy to say. Okay, all right, so now, what CPT codes can I bill, and is it a billable or reimbursable service? It is a billable and reimbursable service. I highly recommend that you use it as a cash system, just because it is so unique. But since it is FDA registered Class 1, 510K exempt as powered exercise equipment. So what that does is allow you to pretty much use most of the physical therapy codes. So 97110, therapeutic exercises. The one I like the most is 97112, neuromuscular reeducation. It really is the thing that defines that the most. And then if you're already using those codes, then I'd recommend like a 97139. Unlisted therapeutic modality, you could go to a 97535, take a look at those and figure out exactly what fits for you. There are billing strategies. I can give you some advice on that. Please understand that that's coming directly from me and my experience in private practice. That is not coming from Ergo-Flex itself. Ergo-Flex is a manufacturer. It is naughty for them to make recommendations on that. So they do not, that's coming directly from my clinical experience, as is most of this, okay? So again, 97110, 112, and 139, those are on the online resource centers. So let's talk about what are contraindications. This is not specifically on the online resource center. I may put it up there. Again, as a manufacturer, you can kind of, look, Ergo-Flex can get in kind of trouble. Well, they can get a lot of trouble for offering medical advice. So me as an independent as consultant and chief clinical officer for them, I can make these recommendations. So first and foremost, bone cancer. We're not going to do anything with bone cancers, active infections, anything like that. Fractures that are less than 6 months old. I wouldn't even consider a tibial plateau fracture that is not well placed, even a distal femur head, condylar fracture or something like that. Those all need to be, that joint has to be movable and it has to be stable for you to be able to apply knee distraction, knee decompression. So bone infection, active gout. You don't want to get into an active gout situation. Grade 2, 3 ligament tear. If it's in place, if you have an MRI that says, look, it's a high grade tear versus a complete tear, it needs to have plenty of time to really get on board and get head back in the right. I wouldn't recommend you touch those in a decompression situation for more than, I'd give it 3 months, right? And you may need to do some type of injectables on it. I wouldn't recommend a steroid, but I definitely recommend PRP, prolotherapy, a stem cell. Those would all make big differences for it. If you got a surgical release to do that, to go ahead and the surgeon understands what you're doing, by all means, as long as it fits within that 6 to 8 weeks afterwards. Now, I wouldn't do it before that. We're good. Grade 1 ligament tears. You need to be very cautious in the acute phase. Just be careful, because if you start doing intermittent traction on those, it will absolutely, it can flare it, okay? So that's why I like starting those with static. I want to just give them some distraction, some very simple myofascial release techniques, neuromuscular reeducation techniques, adjust the area, adjust the spine, and then off we go. But be careful in the acute phases. Now, especially grade 1. Now, grade 2, you need to be, for grade 2s, if I got a patient that comes in that's obviously acute, but I can't find any laxity, but they got moderate to severe swelling, the joint is stuck in place because of the swelling, not because you can't find the lax ligament, right? So the swelling goes down, now that ligament is really lax. So with those, you need to be very, I typically won't touch them until subacute, 2 to 3 weeks minimum. And then I'll start putting them in the program. Again, I start them in static. I want to see, just taking them and distracting them with 12 pounds of force, how they're going to respond, okay? Most all of them respond oh, this feels really good. Okay. And the next day they're really sore, but it feels good. While I like that. That's what I want to see. And then in 4 visits, I'm going to reevaluate and figure out where we go from there. So grade, yeah, grade 3s. If it's a complete tear, that's going to be a surgical event. Now we're into post-surgical care. We'll talk a little bit about that. So loose bodies in the capsule, you're going to have to be really careful with loose bodies in the capsule. If you got joint mice that don't move around a whole lot and then they're sequestered in the middle in the joint, then great. There's nothing wrong with that. But if you have a loose body, especially a bone chip or something along those lines, or you got a piece of meniscus floating around in there, the last thing you want to do is unload that joint, and then that joint, as it comes back together, it smashes that loose body between the condyles and the cup, and it locks, and now they're in emergency surgery, and there's a whole nother gig with that. We don't want to be in that situation. Simple meniscus tears. So let's say you just have a lateral tear or a simple bucket handle tear. That's just not huge, you know, say 5 or 6 millimeters. Okay, you want to be careful with those because, again, you unload that disc, especially, so I don't know if you can see my fingers. So the big things with meniscal tears is that if you float an edge, look, the reason why they're really painful is because they overlap. When they overlap or they get an edge caught or pinched, that's when they really, really hurt, and that's when you start getting a locking event. That's what gets people in immediate surgeries, okay? So the same thing with the complex tears, right? So with simple tears, you want to be pretty much hands-off on those, especially you have a very clear MRI, you got ligament laxity in place. You want to be very careful in the first 3 months, okay? I would be a case-by-case, but typically I did not put them on the knee on Trac within the first 3 months. Doesn't mean you can't do all the magic that you do, right? Adjust, do all the other things that you do as a chiropractor. Please do those. It's just distracting that knee and opening up intermittent distraction. You can slide one of those edges back over. Woo. Now they're in another surgery very quickly, or they in surgery that they didn't really need to be in. We got to be careful with that. Same thing with the complex tear. Give those 6 months. Let them get all the way through the healing phase. Make all the scar tissue. Now you can reorient that scar tissue. Okay, unless you go down the stem cell, PRP, prolotherapy, something along those lines. That's a whole nother thing, okay? When you start doing those types of injections or collaborating with the doctor, there's just a lot that goes with it. It is a tremendously amazing tool, but for acute, subacute, and post-surgical care, you gotta be careful. Again, post-surgical, minimum 3 months, okay? And it depends on what it is. If they had a ACL that completely avulsed away and had to have it re-anchored, I'm going to be really cautious if I go in at 3 months. Okay. Now, if it's a partial tear and they just went in, dusted and cleaning, they shaped up the edges on a meniscus tear, yeah, 3 months, no problems. Okay. I probably want to do it earlier, but I would seek surgical release. Okay. I want the surgeon to know what I'm doing. I want him to understand what I'm doing. I want to tell him why. That's why I want to do it. Okay, because I want to reset that screw home mechanism. I want to make sure that full extension is occurring in that knee. All right, that resets the pump mechanism so that you get better synovial fluid movement, which means you get better lymphatics, which means you get better blood supply to the meniscus, which means you get better blood supply to the neon lateral, collateral, and the joint capsule. All of those different events are what the knee on Trac actually helps the body achieve. But I don't want to be in the middle of post-surgical infection and putting traction on the knee, because unfortunately, you know who's going to get blamed, right? It doesn't matter if the physical therapist is in the room with us, we're going to get blamed. So that's one of the things. Total knee replacements, minimum 1 year. I don't want to be a part, and it's again the same concept. I do not want to be a part of a failed knee implant, okay? Because I'm going to get blamed. I don't want to be blamed for that. Now, if you have surgical release, minimum 3 to 6 months, okay? And I probably wouldn't touch it until 6, because I don't want there to be hidden infection I don't know about, right? Because the infection, whether it's bacterial, viral, or fungus is actually erodes the bone away from the joint. Okay, so be very careful with those. Typically, you're not going to have a total knee replacement coming in your clinic for knee pain relief. You may have somebody with back pain coming in with that same issue, but it's kind of a rare event. But they are out there. But somebody that's got a knee replacement that's more than a year old, you're pretty much solid. You're not going to do anything to break that knee. Okay. What else? So here's one of the big questions we get, especially if somebody's looking at trying to put another knee on track, or they want to put in a brand new knee on track in their clinic. And what are the dimensions? The dimensions, they're 43 inches high, they're 54 inches long, they're 26 inches wide. Okay, so basically where you could put a waiting room chair, you can put a knee on track. And I guarantee you that knee on track is going to make more money in your waiting room chair. Here's the thing. If you want to be able to walk all the way around the knee on track and be able patients get on and off at both sides and even be able to get behind it, it needs a 3x5 space. Okay. Now I have put the knee on track right up against the wall and had no problems with it. Okay. I've seen doctors put multiple knee on tracks right next to one another and everything's fine. Okay. There's no problems with that. But to be able to get around all the way around it, a 3x5 space. Okay. And if you put it catty corner in the corner, it takes up very, very little space. One of the things we talked about, why is the bladder fail? Anybody have any questions? I know you do. There's more questions. Oh, hey, what can I charge for this thing? That's a good question. I get that on a lot. And how often should I do it? So I charged $55 a knee when I was in private practice. So if they did, the same patient did both knees at the same time, I gave them a 50% discount on the second knee. So it was $82.50 for the knee on track for that day. On our average knee protocol case, we charged $4,000 on a prepay for just a knee. That didn't include anything else. That was the knee and everything we did for the knee. Now, it's not just the knee on track. We did an adjustment. There was all kinds of things we did for it. But if we were just doing knee, it was $4,000, which is a very rare event because if somebody has a knee problem, they almost always have some type of lumbar spine or thoracic or cervical issue that needs to be addressed. So on a prepay, those were right at $5,000. So $4,000 just for the knee and all the things we did with that. If it was a lumbar spine with a disc, it was an extra. They went on back on track. We built in those two basic scenarios. So I highly recommend that you couple the two. All right. The back on track is extremely effective at unchoking nerves that actually feed the 6 muscles in front of and behind the knee. Dr. Talley, yep, I did do trigenics on for the knee protocols. Oh, it's a great question, Dr. Schnamm. For the 4,024 visits, I saw them 3 times a week for 8 weeks. I typically only did, so Dr. Talley, one of the things I did with trigenics was we typically only did like 5 visits of trigenics. All right. Didn't have to do a whole lot of trigenics, especially after we started doing the knee on track. And I didn't do them every visit. Okay. I would do trigenics about once a week. So that gave me 5 weeks into the protocol. And so I could clean things up. So if I didn't have, because occasionally you have to go back and reset the PES and the popliteus and so on and so forth. Okay. So you gotta be, I didn't go in there and blast away like Barlow does. I'm a little bit more gentle. I don't go for the fences every single time. Hey, Dr. Nice, good to see you. Trying like let you know I had my first real knee. Hey, all right, cool. Yeah, Dr. Nice, he actually has a really cool story. He just got his knee on track and his back on track. Wow, 75% improvement, one treatment. The staff was astounded. That is an absolute normality, right? So if anybody that is not using their knee on track, unfortunately, that's what we did. We bought a knee on track and it sat there for about 9 months before we figured out how to use it. That is exactly why I'm here. Okay, I am here to help you implement on clinicals so that you can start getting absolutely amazing results, because it does things that, quite honestly, nothing else does. And there's not much that we do as a chiropractor on a regular basis that treats the knee the way that the knee on track does. And it takes a long time. So that's one of the things. Now, what I can tell you is this. I use the WOMAC, okay, and hopefully everybody's heard of the WOMAC. It's the Western Ontario and McMaster University Osteoarthritis Index, okay? It basically gives you a grade on what's happening with that patient. Now, I did not do this on their day one when they initially come in, okay? It's kind of this, if you've ever seen it, it's a great questionnaire, but it's a little bit out there. And until you have the patient actually committed and started care financially and time-wise, I didn't waste my time because it can confuse the patient sometimes. So I would do that. We would do the WOMAC, okay? And guess what? 8 weeks later, we'd have a follow-up. So they do the WOMAC to begin with. We get a score. 8 weeks later, we do the score. Almost always, we had above 90% subjective improvements on the WOMAC, right? And that was whether we were doing stem cells or not, okay? Stem cell, basically, that program was 8 weeks, once a week for 8 weeks, okay? I didn't have to do as much mechanical input because I had the stem cell doing a lot of the work internally. But what's awesome is we would get very similar WOMAC improvements, whether we were doing with or without. Now, the difference is, now look, understand, you don't have to do stem cells to use the NeonTrac. The NeonTrac will do 95+% of all the problems that we have with knee issues, especially total knee replacements, which you're not going to do an injection in that knee anyway. I don't see why not, but that's a whole nother discussion. But you're probably not going to, so you get this crazy improvement that the patient tells you about, which is really cool. You're not asking them. You simply have to say, hey, fill this out, and then we'll do this again in 8 weeks. And you see this amazing result. So it is absolutely a critical component for being able to understand what's happening with your patients. Because, look, I say this all the time, do not buy equipment so you get new patients. Buy equipment so you can get better patient outcomes. That gives you great confidence. That means you're going to get more new patients started in care, okay? So when you do this subjective, objective test, pre and post, and you start seeing the results that you see because of that WOMAC, and the patients see it, and you show them their scores, because they want to see their score, right? They want to know that they're getting better. And then you do an x-ray, and the x-ray is not that great, which it typically isn't after 2 months. It makes all the difference in the world. So the pro tip on x-rays on knees, give them 6 months, okay? Pre and post spine x-rays, you will see huge changes in 2 to 3 months, okay? Knees take 6 months. Doesn't matter if you're doing stem cell or not. It takes 6 months for the body to start to regenerate the joint capsule space and get it stabilized with enough joint synovial fluid production in order to maintain that space again. I haven't exactly figured out the physiological reason why that is. It's just what I see clinically, okay? So what we would do was, okay, we're going to do an exam in 2 months. And then I would, depending on how severe they were, I'd say either I'm going to see you once every 2 weeks or I'm going to see you once a month over the next 4 months. And then we'll do an x-ray. Or I'll see you back in 4 months and we'll do an x-ray and see how it does then. If they have really great results and they were, say, a mild to moderate degenerative. So, and it never failed. That was, well, I thought you were going to do x-rays at 2 months. No, we're not going to do it. No, I understand. We'll see you back in 4 months to do them. Or we're going to see you once a week. You know, and if you're severe degenerative and you're facing a knee replacement, to maintain this, because we know it takes 12 to 18 months for that tissue to completely regenerate and strengthen, it's going to take a full 6 months, a minimum a third of that time, to really stabilize and start to regenerate the joint space itself, if you can do it. So if you take x-rays along the way, patients don't get, I mean, it's kind of a big letdown for the patient. It's a big letdown for the patient. It's a big letdown for you. But functionally, they're way, 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 way better, okay? So, hey, Dr. Nice, using MR4, how many treatments do you use laser each visit? Yes. I recommend, I love the MR4. The MR4 is fantastic. Class 4 laser, super pulsed. I would recommend using it each visit. And that's what we did not, when I was in private practice, I did not have that particular laser. We had a laser 7, which was all hands-on stuff. We did 8. mainly used it for pain relief, and you had to absolutely. I mean, if I didn't have my hands on it, and had a staff that was using it, I would. They didn't use it. All right, and they needed to go in a closed room, put glasses on. Both of them did, just simply because I didn't want anybody to have any type of issue with that. The MR4 multi-radiance has an OSHA 3 rating. Don't quote me on that, but they're OSHA approved for open use. In other words, in an open treatment area, nobody needs to have glasses on. The way they shield it, the way they diffuse it, you do not need to have everyone put glasses on. When I was at FCA National, we were right next door to Light Force, which is a class 4 super pulse, and they have a shielded room. And then when you're in the room, everybody wears glasses, okay? Because if you flash somebody with that particular laser, or you flash somebody with like a K laser, those things are so concentrated at one point and they're not super pulse enough, you'll detach a retina, okay? So that's one of the key events. Got read off. So what about using the rebuilder as well? Fantastic. I love the rebuilder. Now, I typically use the rebuilder in a bath. So I would stimulate from toes all the way to the brain, okay? I've got a little bit of use with the straps. They were good, nothing wrong with them. The thing is that if I'm gonna stimulate that pathway from a neurological standpoint, what am I trying to do? I'm trying to rebuild the pathway. So if I'm going to stimulate from the knee, I might as well stimulate all the way from the toes. That's why I like the rebuilder with in the bath. And you need that 30 minutes, okay? You really do. With what you're trying to do with the rebuilder and or Hacomed or any basic, any electrotherapy, the research is really pretty clear. You need 20 to 30 minute protocols on those, okay? It just takes that much stimulation in order to get things going. But excellent, excellent, excellent. So as far as stacking them, I liked the MR4 and the MR5, both great. I like the laser stem. I'd actually teach the patient how to use the laser stem, and I would put it over the rectus femoris. It attaches into the patella. I would just have them move over that area, and then use the other two shower heads around the knee. We have the forehead system, which is great. Plus laser stem. That laser stem has electrotherapy in it. It's got a neurostimulator in it. So I wanted to actually stimulate, and it's cool. You teach the patient how to do it, or your staff how to do it. It'll actually find the dysfunction in the myofascial system and teach you and actually show you where you actually need to treat, which is really cool. So if you just have them going back and forth over the rectus femoris and the medial and lateral VMO and VLO, where it attaches to the patella, patients get great results with that. Great, great, great system. So they have the laser shower heads, they have the diffuser heads, and I love that laser stem head. That thing's amazing. It does great, great stuff. The laser stem, you got to spend a little bit more time with it. But so typically I have them do that for the first 3 or 4 visits. After that, I just use the laser shower heads. More than enough power to get you everything you need to get photobiomodulation, ATP up, oxygen, so on and so forth. So the other side of that is total brain body O2. So I talked about the back on track. That's actually what opens up the nerves at the lumbar. Total brain body O2 is actually what helps the body drive in oxygen and a cellular respiration. So you need glucose and oxygen to create ATP. If you do it in an anaerobic state, 1 glucose and 1 oxygen creates 2 ATPs. If you do it in an aerobic state, oxygen state, it's 34 ATPs, okay? Creates anti-inflammatory, creates much higher cellular repair and cellular respiration, which is absolutely critical for cellular regenerative therapy. So you do things like laser on top of oxygen therapy with knee on track and back on track, you have a complete healing package, okay? And if you're not interested in going into integrated medicine, you basically have the best way to get cellular regeneration happening without having to do an injection of stem cell. Okay, absolutely amazing. And what I'm looking at right now is shockwaves. That's pretty amazing stuff. The Shockwave is pretty cool. So I won't talk too much more about that. The Shockwave, I'm not comfortable enough knowing everything about it. It is ultra low frequency sound wave. I've had kidney stones pretty much since I was 18 years old. So I know a lot about that technology, but how it affects the body is a totally different thing. Okay. So anybody have any other questions before we zip on out of here? I appreciate everybody coming on board. Again, go on the online resource center. All right. I can't tell you how many times either myself or Donnie or Mercedes or Elizabeth or Josie asked the question, are you on our online resource center? And the answer is no. A lot of docs simply aren't. There is a tremendous amount of information on here. It's updated on a regular basis. There's clinical documentation. There's all kind of great tips and tricks. On top of that, if something happens to the equipment, we can walk you through repairs if we need to. It brings up the fact that, hey, look, it's pretty rare that the equipment breaks, but if it does, it can get kind of expensive to fix it, okay? And so the Neon Trac warranty is, I'm not gonna wrong quote myself, I think it's $595, but heck, most everything on the equipment costs more than that to just simply to buy it from us. So, and that includes, look, overnight shipping if you need it, all the parts, all the warranty. If we can't fix it at distance, JT will actually get on a plane and come fix it, or he'll drive to you, okay? They don't break very often, but if they do, they can get kind of expensive if you're not in warranty. And we offer multi-year warranty discounts. So let's say you want to buy 3 years of warranty. Well, we're going to give you $100 off for every year you buy, the total cost. It's pretty cool stuff, okay? JT and Linda are amazing. They really built this company on the foundation of customer care, customer relations. So you simply, I mean, I remember when I had my American Back Systems table, that was a $3,000 warranty, and it was a limited warranty, and I picked that every year. So for what you're paying on the Back on Track and the Neon Trac, it's amazing service. It's absolutely amazing service. We actually we've actually replaced entire systems just to make sure everything was right. Okay, so guys, if you have not registered for Secrets to a $1 Million Practice, you need to. We only have about 5 seats left. Okay, September 26th, 27th, and 28th. We still have a couple of seats open on the Elite Training module Thursday evening. You're going to get 2 to 3 great hours of one-on-one instruction specifically with me. Dr. Buzz Korth is going to be here, Dr. Tony Doremus. I'm going to have Will Smith. We're going to have some really masterminds in the field of alternative medicine and chiropractic medicine on how to turn this into a huge enterprise for you. Get your patients better, improve your bottom line, and get better patient outcomes. That's really the biggie. September 26th, 27th, and 28th. We only have a few left, and our prices are going to be going up pretty soon. So, Dr. Talley, I've had one issue in 2 years. JT drove to Oklahoma and repaired my Back on Track in about 10 minutes. They are awesome pieces. This is the typical. If something happens with your Back on Track or your Neon Trac or your total brain and body O2, and we can't fix it at distance, I guarantee you we're going to be there as soon as we possibly can. It's just the way it is. I mean, look, things happen in shipping. They just do. Okay, electrical storms happen. They just do. And if something goes wrong, this company will absolutely back up its product 100%. And we take all considerations in place. Okay. So again, September 26th, 27th, and 28th, Secrets to a $1 Million Practice. I'm going to be going over all of the in-depth details on why this equipment works, not only mechanically, but from a neurological reason. Okay, why can you fix folded ligaments in a total knee replacement? Why neurologically, what you are doing is actually creating a tremendous effect on the brain and the entire mechanism. We'll be doing about all three pieces of equipment. The Neon Trac, Back on Track, and Total Brain and Body O2. We will have the Cervitrac, which is the cervical attachment for the back on track with Ergo-Flex. If you got a back on track, this will fit right on there. We are taking pre-orders for them. I'm not telling everybody about it, except y'all. The pre-orders right now, we've got an introductory price of $8.95, and that price is going to be going up, so you better take advantage of those. We are in production. We are putting the final touches on the Trac. It's absolutely cool. We've been hearing this over and over and over again. When you're going to get a cervical traction event, it is super simple to use, and it gets amazing results. It is absolutely cool, and it's comfortable. It's mostly comfortable, which is something that's kind of hard to say for most cervical traction events. It's cervical traction and curve restoration hybrid model. It's pretty cool stuff. So you'll be hearing much more about that here in the near future. So thanks a lot, guys. I appreciate you being on board. If you have any questions, you can always reach me at dr.wyatt@backontrack.com. You can call us here. I'm happy to get on the phone. My cell is 281-382-4875. Again, 281-382-4875. If anybody wants to give me a shout out with the text, I'm happy. Texts are usually the easiest way, but I'm happy to get on the phone. If you need any specific one-on-one training for yourself or your staff or anybody else, I will get on a Zoom call very much like this, and we will hash it out, and I will make sure that you are up and running on every level that we can possibly get you there. If you want to talk about billing strategies, you want to talk about how to build an evidence-based treatment plan, if you need help on sales and how to present to a patient in a day one, day two, I am happy to do all of those things for you and help you out. I'm not going to do them for you. I'm going to help teach you how to do them. All right, guys, keep saving lives. Call us up or get online and get your ticket to Secrets to $1 Million Practice. Those seats are flying out the door, and I don't know how many more we're going to have left after this particular webinar. All right, guys, great having you all on board. Hey, did you get it, Dr. Talley? I put it up. Looks like you did. Hopefully. Yep. All right. Awesome, guys. Have a great one. We'll see you soon.